Hello there, my name is Priyal Taribagil. I have recently graduated from UCL Medical School and will be starting my academic foundation training program in London very soon. The aim of this tutorial today is to provide you all with a greater insight into paediatric conjunctivitis. In particular, I will be talking about the theory and causes of conjunctivitis, signs and symptoms, management, and finally, neonatal conjunctivitis. I'd like to start off this tutorial with a quick case study, just to get you all thinking. The scenario is as follows. A 3-year-old boy comes from his nursery with red, itchy eyes. He continues to rub them and has been increasingly irritable throughout the day. There is some crusty discharge around the eyelid margin. So this is a classic case scenario for a child who is presenting with conjunctivitis. It is important to ensure that we do not miss out on any red flag signs or symptoms in such cases. This could include things such as an acutely painful eye, photophobia, ophthalmoplegia, recent trauma, or loss of vision. The presence of any such symptoms would warrant urgent ophthalmic review, leading to an entirely different diagnosis and management. To begin with, it is important to understand what conjunctivitis actually is. It is commonly defined as inflammation or infection of the bulbar, tarsal, or palpebral conjunctiva. These are shown on the diagram above. Causes can be grouped into 3 categories: viral, bacterial, and allergic. Viruses that are commonly associated with this include adenovirus and herpes simplex virus. Bacterial causes include Staph aureus, Streptococcus pneumoniae, and Haemophilus influenza. Bacterial conjunctivitis is responsible for the majority of cases in children. Allergic causes. These are generally due to a particular allergen, for example, pollen or house dust mite, just to name a few. In pediatrics, conjunctivitis is often a common feature of the well-known allergic march phenomenon. This refers to the natural history of atopic manifestations in children. During infancy, babies can present with eczema or specific food allergies. This can later progress to allergic rhinitis and conjunctivitis, and eventually into asthma in the preschool years. Signs and symptoms. Common symptoms of conjunctivitis include a red eye, irritation, grittiness or discomfort, and discharge. Common signs include conjunctival injection with dilated conjunctival vessels, chemosis, which is edema of the conjunctiva secondary to abnormally permeable capillaries, the presence of papillae, which are raised lesions that can vary in size, with giant cell papillae giving rise to a cobblestone-like appearance under the upper eyelid. They are generally a non-specific sign of chronic inflammation, but it is very typical to see them in allergic conjunctivitis. And finally, the presence of follicles. These are gelatinous oval lesions more commonly seen on the lower tarsal conjunctiva. These are present in viral and chlamydial infections. Below is a table summarizing the difference between viral, bacterial, and allergic conjunctivitis. Features of viral conjunctivitis include a watery discharge, follicular conjunctivitis, as explained above, and preauricular lymphadenopathy. Features of bacterial conjunctivitis include the presence of purulent discharge. And finally, features of allergic conjunctivitis include a watery discharge and vernal conjunctivitis, which is a seasonal allergic conjunctivitis that is more commonly seen in young boys and often occurs at the same time each year. Investigations. Paediatric conjunctivitis is generally a clinical diagnosis based on history and examination. Swabs can also be considered. Management. The table below highlights how different types of conjunctivitis are managed clinically. For viral conjunctivitis, the management is mainly supportive, with the use of topical artificial tears if required. Bacterial conjunctivitis, on the other hand, can be treated with topical antibiotic drops, such as chloramphenicol eye drops, which can be given for a duration of 5 days. This helps to speed up the recovery. Artificial tears can also be used as an adjunct. Finally, the management of allergic conjunctivitis involves identifying and avoiding the triggers. If required, children can be started on topical mast cell stabilizers or topical antihistamines, as deemed appropriate by the clinician. For all types of conjunctivitis, maintaining good hygiene is extremely pertinent. This includes regularly cleaning the eye with cotton wool that has been pre-soaked in warm water. Recovery can take up to 2 weeks if the cause is infective in nature. However, no school exclusion is required. The final part of today's tutorial will be focusing on neonatal conjunctivitis, which is a subtype of paediatric conjunctivitis. The case study below will give an example of this. A 10-day-old baby girl presents with discharge coming from her right eye. It began a few days ago with a watery consistency and has now become mucopurulent in nature. The neonate was born via a normal vaginal delivery. On examination, the neonate is afebrile with stable observations. However, there is swelling and conjunctival injection over the right eye. This case is very typical of ophthalmia neonatorum, also known as neonatal conjunctivitis, as this occurs within 28 days of birth. This is a form of conjunctivitis that is contracted by newborns during the delivery, as the baby's eyes are often contaminated during the passage through the birth canal, if the mother is infected. Causative organisms include Neisseria gonorrhoeae, Chlamydia trachomatis, which is the commonest causative organism, herpes simplex type 2, and other organisms such as Staphylococcus aureus, Streptococcus hemolyticus, and Streptococcus pneumoniae. Investigations. These involve taking swabs from the infected conjunctiva before starting treatment. The table below highlights the key differences between gonorrhea and chlamydial causes of conjunctivitis. Gonorrhea is most likely to cause an infection from birth and up to 5 days after birth. Neonates will have a bilateral purulent discharge that is often also associated with some local inflammation. The treatment involves the use of IM ceftriaxone or IV cefotaxime. Chlamydia. This is most likely to cause an infection between day 5 up to 2 weeks post-birth. This generally starts off as a watery discharge, which then becomes mucopurulent over a period of time. There is generally less inflammation associated with this. Treatment normally involves the use of oral erythromycin for a duration of 10 to 14 days. So, going back to the case, it is likely that this child has a chlamydial infection, but will require conjunctival swabs to definitively prove this. So, to summarize, we have compared and contrasted the causes, investigation, and management of conjunctivitis in children. We have also briefly discussed neonatal conjunctivitis and the differences between its management. I have put together a list of resources that I have used to make this video. Thank you for watching this tutorial, and I hope you have found it useful.